Welcome to AETCM, the emergency medicine channel.
Yes.
A 26-year-old male presented to ER with complaints of abdominal pain, fever, and vomiting, and reduced urine output since last 4 days. Sir. On initial 10-second assessment, patient was conscious oriented, and then we started the primary survey. Airway appears patent, no secretions, and breathing respiratory rate was 20 per minute with saturation of 100% on room air. Air entry was bilaterally equal, and circulation BP was 140 by 110 mmHg with pulse rate of 160 per minute. And at this point of time, 2 large bore IV cannula were put, and blood samples and ABG were sent for. Disability GCS E4 V5 M6 with pupils 2 mm bilaterally reacting. Exposure temperature was 104.2 degree Fahrenheit. So we had at this point of time given him 1 gram paracetamol IV injection, sir. And GRBS was 150 mg per DL. In the primary survey, patient was having a higher temperature with increased pulse rate, for which we had given a paracetamol, post which the patient's pulse rate had come down. Next, coming to adjuvants of the primary survey, the VBG was taken, sir.
Okay.
In VBG, creat was 4.31, sir, elevated creatinine with normal acid pH of 7.43 and bicarb of 26.
26.
Normal acid-base disorder with higher elevated creat, sir, and potassium was 3.4, sir.
Okay.
After that, we had taken a point of care test, and point of care CRP was 230, sir, and WBC counts were 18.8. So at this point of time, we are suspecting a patient with with an infection.
Okay.
And kidney injury because of higher elevated creat, and symptoms was reduced urine output. Now coming to the secondary survey, 26-year-old male had complaints of fever for last 1 week with lower abdominal pain, bilateral lower abdominal pain for last 4 days, and vomiting for last 2 days, which was containing only food as a constituent, sir. And he had reduced urine output for last 3 days, sir. This is the basic history. And he had complaints of dysuria initially. Before this reduced urine output, he had a history of dysuria and shivering for 3 days. History is there, sir. But there is no any history of hematuria, no history of any breathing difficulty, no history of chest pain, no history of any skin rashes, and no history of any trauma or any such sort.
Okay.
Coming to the physical examination, head-to-toe examination, patient had no icterus pallor.
Why you asked about the history of trauma? What is the importance of trauma history in this case?
To this case, basically patient having lower abdominal pain, any pain.
Trauma to that area.
Trauma to that area.
Okay.
Yes, for that. Next, examination point of view, sir. Head-to-toe examination, no pallor, no icterus, no clubbing, no cyanosis, and no pedal edema, sir. And coming to systemic examination, the patient chest was air entry bilaterally equal, normal vascular bed sounds, and in circulatory system S1, S2 heard, and no additional heart sounds. So, abdominal examination, abdomen was soft, and there was tenderness in the flank region, sir, tenderness in bilateral flank region, and other than that, bowel sounds were present. Further, for evaluating purposes, we got an ultrasound abdomen done initially to rule out the tenderness, and ultrasound was showing bilateral bulky kidneys, but no HUN or no any perinephric fat collection or nothing is mentioned. Okay. And we had our routine blood investigation sent, in which procal was greater than 100, CRP was 330, sir, and WBC counts were 18,000, with urine report, urine routine was showing numerous pustules with 3+ leukocytes, bacteria present, and nitrate negative, sir. So in view of the ultrasound,
Nitrate negative means what,
sir?
Nitrate
negative means gram, we are not suspecting a gram negative bacteria
okay.
in the at present.
Okay.
With respect to that, we further, for better radiological examination to see if there is any perinephric fluid collection or anything, we got a CT KUB done. In CT KUB also there was only bilateral bulky kidney, but they had not commented upon any fluid collection or HCN or any of the sorts.
Okay.
So patient had
What
now
fluid collection you are thinking of in kidney?
nephric abscess.
Perinephric
abscess basically.
Okay.
The report showing kidney injury AK especially with the background of the infection, we can consider it to be an UTI urosepsis the patient is having. But clinically patient is complaining of flank pain, so we can consider him having bilateral pyelonephritis as the initial preliminary diagnosis.
What is the evidence of sepsis here?
Sepsis. Infective markers with fever history. Plus one organ damage, which is the kidney is damaged here because creatinine is high and urine output was reduced.
Okay.
In view of this, we have checked the IVC. IVC was collapsing, so we had hydrated the patient.
What is the BP of this patient?
140/90 sir, on arrival to the ER.
140/90. Do you think that your ultrasound shows collapsibility and BP being 140/90?
Sir, might be a patient in fever at that point of time, because of which heart rate was also high and
something is wrong. Like either your BP recording or your IVC measuring this one, or something else had contributed to this.
The fever might have.
Fever will not increase
BP.
Okay. What might have happened? BP is normal. IVC is collapsing. One of the thing is wrong. Either you had taken BP much earlier and ultrasound was done later. One of the thing is wrong. Okay.
So patient was hydrated. A patient after starting the hydration, he was having 40 to 50 ml per hour urine output constantly, sir. And we had been monitoring creatinine on a daily basis. First day it was 3.8 on arrival, then next day it became 4.6. And gradual it has been downtrending and it has come to normal 1.1 at the.
Okay.
Apart from this lab values, patient had an elevated creatine kinase. 22,000 was the elevated creatine kinase, and we had checked for an urine myoglobin to detect if there is any rhabdomyolysis. Urine myoglobin was positive. So
what are the possibilities to have a high creatine kinase in a patient like this? Possibilities. Leptospirosis. If the patient is having leptospirosis, he can have high fever, he can have renal failure, he can have high creatinine, he can have high creatine kinase. All these things are possible. One reason is leptospirosis. Then whatever you want. Myocarditis, CK will not be elevated, no? CKMB will be elevated, CK will be marginally elevated, not to this extent.
Next, if there is any infection of the muscle, myositis.
Polymyossitis. Infective polymyossitis. Okay.
Or if there is any crush injury.
You are telling there is no history of injury. I am asking what are the possibilities. I don't tell that is a problem in this patient. What are the possibilities?
Any electrical shock or a seizure activity.
Electrical shock can be there.
Seizure activity.
The patient might have developed seizure. That can increase. Okay, then.
Trauma as such.
Okay, then.
Drugs actually like statins.
Okay. Some drugs like statins or many other drugs can produce polymyositis. Acute inflammatory polymyositis is common. Okay, then. What is polymyositis? Actual polymyositis. This is post-infective inflammatory polymyositis. But there is an entity called as polymyositis.
That is an immunological
dermatomyositis and polymyositis. What is it?
And like the antibodies being produced against the muscle proteins with the polymyositis.
So they can have muscle pain with muscle weakness. Which muscles are involved there?
Distal.
Proximal. That is mostly all myositis are proximal. There is only one myositis which is distal. What is that myositis? That you have to read. Only one myositis will produce distal myositis. Okay. Inclusion body myositis. That is a different this one. It will not produce this much weakness. It will not produce this much muscle wasting. Okay. Okay.
So for this, the patient was then initially started, as the patient was having this, initially started with IV antibiotics.
No, you tell me according to your priority here. You have a patient who is having high degree fever. CK is very high. Renal failure is there. What is your first priority? Myoglobin is positive.
Hydrating the patient.
Hydration is most important in this case. Okay.
Yes.
We don't know whether the renal failure is due to this muscle rhabdomyolysis is leading to kidney injury or not. So hydration is most important. So did you hydrate this patient?
Yes. The target goal for hydration was like getting an urine output of 100 to 200 ml per hour,
Okay.
maintaining that.
So that is very important. So start hydration. Then after that?
After for the component of infection, giving antibiotics.
What antibiotic you want to give here?
Here, as we are suspecting pyelonephritis, we wanted to give an carbapenem class of antibiotic.
Which antibiotic you have?
Meropenem.
Meropenem. What is the dose?
Meropenem 1 gram TID.
You can tell. 1 gram TID.
Yes.
Creatinine clearance should be easy.
First initial 24 hours, we can give the patient the loading kind of thing. After that, as per the creatinine clearance, we need to adjust the dose.
What will be the creatinine clearance in this patient? What is the calculated creatinine clearance in this patient? What, as a routine practitioner, what it can be? What is the calculated creatinine clearance? Is it important?
Yes, sir.
It is very important. Calculating creatinine clearance is very important to give an antibiotic, anesthesia drugs, all these things. It is important.
3.8 was the create with 19-year-old.
Less than 25% of the kidney. So 75% must have damaged by this time. So less than 25%, most of the drugs OD dose will be enough. Okay, maximum 1 gram OD or 500 milligram BD will be enough. Meropenem. Okay. Suppose we give full dose, what will happen?
There will be accumulation of it. The clearance will not be happening of the drug.
10 to 5 minutes. So seizure threshold can be reduced. So these drugs can produce seizure. Okay. Now what is this case?
This case bilateral
pyelonephritis with inflammatory polymyositis. So when you have an inflammatory polymyositis, you have to see whether it is a post-infectious inflammation or something else. Something else is the actual polymyositis, that is a immune-mediated disease. So in that case, you have to search for other reason like redness of the skin, redness of the eyelids, all these things.
Okay. Skin
changes and dermatomyositis you have to see. And see whether any past history of similar complaints. All these things. Okay. Was there any similar complaints?
No history of such past history.
Okay. Now what happened to the patient?
The patient has been like we started giving steroid therapy for his myositis components.
Okay.
Apart from that, with the antibiotics, the patient got better and creatine has come down.
Only under the cover of antibiotics you are supposed to give steroids. Actually, steroids are not a good choice in this condition, but since we need to have a faster recovery, you are using steroids. Otherwise, steroid has got no major role in this. Yes. Only antibiotics subside the infection, everything will become normal after some time. Whereas in polymyositis, dermatomyositis, how do you treat?
There we need to give
so suppose there is no infection here, you are getting same patient with a polymyositis, actual polymyositis.
Anti-inflammatory.
How do you treat?
Anti-inflammatory and anti-steroids.
I will finish it now.
Yes.
Have some work important. Okay, so there you have to give pulse therapy. Okay, that is very important. Okay.